We have 25 dentists working together interdisciplinary as a team. We work a lot of restoration here, full mouth rehab, aesthetic cases, implant cases, orthodontic cases, and also surgery. So I have experience with the concept to pose or not to pose, to crown or not to crown. And we just moved to new building with a better facility and more fresh. You can visit our website at www.indodentalcenter.com. We are located in the heart of Jakarta. So if you visit Indonesia, you can contact me and we are very welcome. So, back to the topic. After years I'm practicing dentistry as a prosthodontist and lecturing in the university, lately I face the difficulties in teaching my postgrad student about pose and crown. Do we need to remove the amount of tooth structure? How much tooth structure we need to prep? What about if there's no retention for the restoration? This is the biggest problem that we face in endodontically treated tooth. How should we restore it? I love this article from International Endodontic Journal. There are two approaches in restoring endodontically treated tooth: endodontic approach and prosthodontic approach. Which one are correct and which one are wrong? They are comparing the volume of the tooth hard tissue loss after caries removal, after cavity preparation, after fiber pose space preparation, and after cast pose space preparation. And they concluded that there are two procedures that damage the tooth the most. First is when you do the excess cavity. The second is when you do preparation for post restoration. Yes, of course, we have to remove the caries, that we have to do it. And of course, we need the cavity to be prepped well. But we have to take care of the crack propagation, stress distribution, and everything. But the removal of tooth structure, when we do post preparation, we can minimize it or avoid it. If you're talking about pose, to simplify, there are two kinds of pose: the rigid one and the non-rigid one. If we're talking about the rigid one, there are two kinds of rigid pose. There's the cast pose and prefab pose. As a prosthodontist, I used to love the cast pose so much because its precision, the hardness, the fitting, and everything. But I didn't realize that the cast pose, especially when I use the precision drill for the prefab pose, that can cause damage around the tooth. So, in this session, we're going to talk or discuss about the non-rigid one. What is non-rigid pose? Non-rigid pose is a fiber pose, or we can make custom fiber pose. If you're talking about fiber pose, the things that we have to see is the shape of the fiber pose. Generally, we know in the market there are two types of pose: the parallel pose and the tapered pose. These two kinds of pose that we can find in the market, usually people like this pose because we've been taught the parallel can have more resistant form. We've been taught about resistant form for our restoration. But can you imagine if you put this pose or we prepare this pose in the root, we damage the tooth structure. But with this shape, this kind of pose, we can preserve more tooth structure. That's why I suggest always to choose the tapered fiber pose. Let's say we choose this tapered pose. What about the diameter? Which diameter is good or suitable for ovoid root? If we have root like this, and we choose the diameter of the pose like this, or we have to enlarge to fit the pose to get retention. Remember, when we enlarge the diameter of the pose, we weaken the tooth. Based on Costa 2012 and Battle 2009 studies, the adaptation of the fiber pose, whether big or small, there's no significant difference in terms of retention of the fiber pose. So, based on that studies, I always suggest to choose the smallest diameter. Because if we choose bigger diameter, we need to remove the tooth structure. We need to prep to fit the pose, which is there's no significant different retention between the big and smaller pose. So when we choose the small diameter of the fiber pose, we face the big ovoid canal. How we feel the empty space of the root canal? There's two ways to fill the space between the pose and the wall of the root canal. First, I use the high field resin cement like NHM from my showroom. And the other way is I custom my fiber pose. How to custom the fiber pose? Usually I treat the fiber pose using hydrogen peroxide. I soak in the hydrogen peroxide 24% for 3 minutes and then rinse it. And then of course after that I saline 3-4 times, 5 times, and then heat it. After I heat it, and then I apply the bonding on the fiber pose. After I cure the bonding on the fiber pose, I apply preheated composite. Preheated composite is very good because the flow of the material. I put glycerin gel in the root, and then I put the fiber pose with the composite into the root. I insert into the root, and then I take cure for 3 seconds from buccal and lingual. And I take it out, make sure there's no retention, and I cure extraorally the custom fiber pose. So, when we choose the small diameter of the fiber pose, mostly we face ovoid root canal. Then when we insert the fiber pose, we see so big gap between the fiber pose and the wall of the root canal. The problem is how we feel the gap between the fiber pose and the root canal. There's 2 ways to fill the gap between the fiber pose and the root canal. First is I use the dual cure high field resin cement. Dual cure high field resin cement like NHM from Mycerium. I like the dual cure because I am sure that the cement can cure completely in the root canal. But there's a study from Faria Silva 2014, the effect on delay polymerization. So I suggest if we use the dual cure cement, always delay the light cure, because when we do the light cure, the potentially of shrinkage of the cement is quite big. So always delay 3 to 5 minutes. Let it cure chemically, then we can cure with the light cure unit. The second way is what we call custom fiber pose. Custom fiber pose is what I do in the clinic every day. How to do the fiber custom pose. Take your smallest fiber pose. Treat your fiber pose with hydrogen peroxide 24%. Soak it for 3 minutes and then take it out and rinse. After you rinse, apply the saline, heat it, apply, heat it 3 to 5 times. After you apply the saline, you apply the bonding. After bonding, you cure it. After it cures, I always apply the preheated composite. Apply on the pose, the preheat composite. And before I insert in the root canal, I put glycerin gel in the root canal. Then I insert the fiber pose with the preheated composite. I insert it, I take it out a little bit, and then I cure, just to make sure there's no retention. Put it in, take it out, and then cure it extraorally. When the custom fiber pose is ready, you can ultrasonic bath, clean it with the phosphoric acid, and then you just cement it with dual cure resin cement. If you're talking about the depth of the pose, how far, how deep should we put the pose? 7 millimeter, 12 millimeter, or only 3 millimeter? There's an interesting study from Santos and friends in 2014. They shows that the stress distribution on the tooth between the 7 millimeter depth from the coronal and 12 millimeter from the coronal, there's no difference significantly in stress distribution. If we use fiber pose, one of the most important part is what we call ferrule. What is ferrule? Ferrule is tooth structure that we need at least on the coronal part, 1.5 to 2 millimeter high, 360, and 1 millimeter wide or thick. 1.5 to 2 millimeter high and 1 millimeter thick. That's what we need. But in daily practice, when we see the broken tooth or endodontically treated tooth, usually we cannot have 360 ferrule on the tooth. For instance, for the anterior tooth, central incisor, at least we need wall or ferrule on the palatal side. Why we need on the palatal side? Because its force on the anterior teeth is lateral force. So we need ferrule. We need ferrule on this part. Well, this is the case. This patient is a young boy, 15 years old. He fell just after playing the football. He just went to 4 dentists, and all the dentists told his mother that this tooth need to be endo treatment. Specifically, of course, with pose and crown. But I'm wondering, and also the mother refused. I checked the tooth, it was still vital. Yeah, it might need endo treatment in the future, but not now. I really trust bonding for these cases. And I asked his mom the fragment. I start cleaning the fragment using the intraoral alkalizer, such as AquaCare. Don't use burr to clean this fragment. And I isolate this case with Nictone Rubberden. I like the color so much. And I start my bonding protocol. I cement it with preheated composite from Mesoerium. And here is the result. If you look at this in this picture, the fragment is slightly brighter because of the hydration. But look at this picture. 3 years post-op. The color blends so nice. And I checked the teeth is still vital. The boy was very happy, especially his mom. If we evaluate this case, 3 years post-op, how beautiful is the result is. The blending of the tooth. And after all, the tooth is still vital, surprisingly. If you flash back, do you think it's worth it to do endo, pose, or even crown for this tooth? How badly damaged this tooth will be, especially if we don't work with master ceramists. I don't think it would be possible to create such a natural beauty restoration. On this case, a young lady around 20s came with her severely traumatized tooth years ago. The apical formation was not perfect, and the tooth is now discolored, slightly black, and the aesthetic bothered her, of course. And my fellow endodontist did the circumferential filing, ended the apical plug with MTA. After the tooth is clean, and I saw that it is very thin, do we need to pose and crown for this case? With the thin wall root, do you think I will need to prep further using my precision drill just to fit my pose perfectly? But the damage will be further on this root. On this case, what I did, I took the smallest diameter of fiber post and custom the post with composite. I used the post as a pre-cure insert to make sure the shrinkage on the root will be the smallest. So, from the finite element studies, it shows that with this custom post, the stress distribution shows least force on the root. If you look at this X-ray image, I cemented the post with Enachem from Mycerium. It's a high-field resin cement. If you look at the X-ray, it's beautifully opaque. And also that makes me secure because it's high-field resin cement. And of course, before I do the prep, I take a photo with polarizer and a gray card so I can follow the elaborate protocol that introduced by a young great ceramist, Sasha Hain. Then I make a replica of the abutment just to make sure on the final digital try-in I could mimic 100% of the situation with elaborate protocol. I digitally check the LAB with the opposing tooth to make sure I will have the perfect color tooth even though the abutment color is so dark. With this approach, I could do a single central beautifully even though I am not working with the master ceramist. And after the restoration is ready, I isolate the tooth with KSK 44 clamp, check the color, check the fitting, and I cement it with preheated composite from Mycerium. And after cementation, if you look at this case, compare the previous case without pose and without crown, now we see this tooth is heavily damaged and I restore with pose but without crown. There's a study from Pascal Magne, influence of no ferrule and no pose build-up on posterior tooth. There are three types of restoration. First is normal core build-up and crown. 2 mm core build-up with onlay and the endocrown. And the summary is from three types of restoration. It shows that the 2 mm build-up core with onlay and endocrown shows the least failure compared to the other. And here is the case. This old lady, she came to my office and begged not to extract the tooth. And I tried to isolate this. Based on these studies, I did the restoration without no pose and no crown. Here's the crown, the endocrown. I'm using Enamic, the hybrid ceramic from Vita. I isolate and I cement it with Enachem from Mycerium. On the right picture, after 1 year, we see the X-ray image. It's still intact and function perfectly. If you look at this case a years back, if I did the extraction and put the implant, imagine the leftover tooth was supposed to be extracted. If a years ago we extracted, obviously she will need another implant. But now it is functioning well. If the root we decided to keep it and we took the precision drill and prep it into the root further, how weak the root going to be and how excessive the treatment would be. Therefore, on this case, I prefer not to pose and do an endocrown, and I'm glad I did what I did since the post-op shows its function well and how happy she is now. So, minimally invasive dentistry is not just about cutting less. It's about preserving the tooth structure, such as how we avoid the failure is going to be and the crack propagation. So when the time for failure comes, we will still have enough tissue bank for another restoration. Lately, I've been using composite preheated cement as my luting cement for my restoration. As I believe so much in composite for my restoration, and with heating it up to 55 degrees, my composite will flow beautifully. And it's way much more easier for me to clean the excess. There's a journal state that tech cure and clean and clean and cure shows a significant difference and prevent initial crack with clean and cure. And when we are talking about bonding, to have a clean surface is very important. I've been cleaning all my tooth surface before I cement my restoration with Aqua Care, with silk powder. Silk powder has norphamine and shoot down the sensitivity on vital tooth and also clean the surface for better bonding. So, after I clean up the tooth, I treat the ceramic, the intact surface with hydrofluoric acid 9% for 10 seconds, and then apply the silane for 3 to 5 times and heat it. And then for the tooth, I etch for 20 seconds and then dry it and put bonding. I use 4th generation bonding system, but be careful, don't cure the bonding. And I apply the preheated composite. But before that, I heat the composite for 10 to 15 minutes before I apply the composite on the tooth. And then put the restoration slowly and then push it slowly. It's easier for me. Of course, this technique is a little bit take time compared to normal luting cement, but it's easier for me to clean it up, the excess cement, the excess composite. I push, I clean, I push, I clean. Usually you see the excess cement, clean it until you push the restoration, there's no more excess cement come out. After that, I put the oxygen barrier material and I cure it. Tech cure, buccal, lingual, and occlusal. After it cure, I polish with the silicone. You see the margin is very good. It's not the Hollywood cases. These are daily practice cases. But with composite cement, I feel more secure with minimally invasive restoration like Emax or Anamic. So you've seen extreme daily cases. The question is when to crown, when not to crown. For me, I do my crown only 2 reasons. First, if I have to replace the existing crown. Second is when I see a heavily damaged tooth 360, then I do my crown. Let's say we choose not to crown. What kind of restoration that we need, especially on posterior tooth? Because there's so many type of restoration. We know inlay, we know onlay, we know overlay, now we know endo crown. Of course, inlay on MOD vital tooth, we use inlay. But sometimes we need to cover partially. Then we need onlay on vital tooth. What if that's on non-vital tooth? There's so many studies suggest and supporting to cover the cups on non-vital tooth. So I would suggest to use overlay and endocrown for your non-vital tooth restoration. To prevent further damage, I always cover the cups on non-vital tooth. So basically, what is the difference between endocrown and overlay? Overlay is a type of restoration only on the occlusal part. But endocrown is slightly different. In endocrown, you have a deep part on the fossa area. So, what is the advantage of endocrown? How deep should we put the box on the endocrown? For me, 2 millimeter is enough. This is the advantage. Because why? First, I have thicker material on the fossa part. Second is, it's easier for me when I do the cementation to sit the restoration completely on the tooth. How thick is the minimum requirement for onlay material or endochrome material? With dilithium silicate, at least we need 0.8 millimeter. Of course, if you have more than 8 millimeter, that will be stronger, that will be better. So, when we are talking about bonded restoration, there's so many type of material that we have to know which one is the best for bonded restoration. We know indirect composite, there's the bondable restoration also, hybrid ceramic and ceramic. And ceramic, we know in the market we use feldspathic and lithium disilicate, which is dilithium silicate is one of the material of choice nowadays. But I've seen so many cases, successful cases from Professor Mangani with indirect composite and also hybrid ceramic from Pascal Magne, and so many cases from all around the world with lithium disilicate. So which material you choose is up to you, because all that bonded restoration with indirect composite, hybrid ceramic or dilithium silicate, that's all very good for bonded restoration. Now, we've learned when to crown and not to crown. What about when to pose and not to pose? If I have 4-wall tooth fracture on endodontically tooth, I choose not to pose. Or on damaged tooth with no ferrule, with pose or without pose, there's no significantly different in force distribution. But we have to take care. Just make sure the force is least on the tooth to make sure the longevity of the restoration. Okay, we have learned so much on so little time, and there is too little time to explain all of the details that I need to be explained. But I hope we all could learn and grow together following after this lecture. And you all could learn so much from my past experience in our continuing education in Jakarta, Indonesia. For more info about it, you can email to indodentalcenter.com. My name is Leonard Nelwan. I hope you are blessed with this short presentation, and God bless.